Tonight we're going to talk about a pretty perplexing medical social criminal concept.
The Dan Yorke State of Mind program is brought to you in part by Lookout Rhode Island and Takeo Comfort Solutions.
You know, we've got mixed feelings and we're all over the map when it comes to drug use in this country, but one of the things that we have spent a lot of time on this show discussing is the opioid crisis, and it has changed the dynamic of drug enforcement, it has changed the dynamic of health and human services, it has changed some of the myths. Some of the myths about drug use, I think, have finally come to be better understood. There's a general feeling that drug abusers are people that make their own mistakes, and you know, what are you going to do until your neighbor, your cousin, your uncle, your friend, your coworker tells you that they're addicted to opioids because, I don't know, they had a back problem or a knee problem, and boy, the Vicodin just kept coming, and now they need it, and it really is crazy. Now we've got a bill that is, interestingly, moving through the legislature at semi-normal speed here. The Senate passed by like a 22-11 vote to move the legislation we're going to talk about tonight, and the House was discussing this last night. You're seeing the program on Friday because we tape our Friday programs on Thursday. I would think by the time, no matter what the House has done with this, that the governor will be contemplating whether to sign this bill or not. And so there's still time, I think, for the public to chat about this. And of course, during an election season, everything is up for grabs. I have two experts on this matter who have recently written an op-ed piece that I think you just saw on the screen as a headline. Let me give you some background from Eyewitness News on this, and then we'll introduce our guests.
Arrived at the hospital. She was gone. She had overdosed.
Desiree Sandoval is talking about her 18-year-old daughter, Olivia, who she says died of an apparent drug overdose just 2 days ago in Providence.
Whoever supplied the drugs had to know what was in it.
She came to the State House Wednesday night to watch members of the House Judiciary Committee vote on a bill that would allow drug dealers to be charged with murder if their customers die of an overdose.
The man that gave my daughter the drugs should be held accountable.
The bill is dubbed Kristens Law after Kristen Kutu, a Cranston woman who overdosed on fentanyl in 2014. House Speaker Nicholas Mattiello is the lead sponsor.
I believe that if you're selling that kind of a product, you know that someone's ultimately going to die as a result of them using that product, and the punishment should fit the crime.
But many in the drug treatment and recovery community are concerned it would hurt, not help, people addicted to opiates.
A lot of times in these scenarios, the role of distributor and active user or victim is interchangeable, and I'm afraid that this is going to create like a reverberating fear within the using active use population.
The bill was amended to add a Good Samaritan clause so those who seek medical treatment for a person overdosing won't be charged, and the prison sentence has been changed from mandatory life to up to life, giving a judge discretion on the punishment.
I believe it will save some folks' lives.
So this is fascinating. You know, the speaker, I think, is earnest about his commentary there. But it dawns on me as I introduce my guests here that sometimes those of us who don't know what the hell we're talking about really ought to listen to the people who do. I know that's a concept that's, you know, a little foreign to politicians sometimes. You're laughing? So are you laughing? Dr. Zoe Weiss is from Brown, Alpert Medical School, and a Lincoln native, so she's a local. Most folks from Brown come from somewhere else, so it's good to have a native Rhode Islander. Welcome to the show.
Thank you.
Appreciate it. And Dr. Jody Rich is the director of the Center for Prison Health and Human Rights. I didn't even know existed at Miriam Hospital. Is that a big, welcome, is that a big organization that you got there, or is that your own concentration? You're an internist, right, and infectious disease guy as well?
Yeah.
So what kind of operation is that? Let's set the table first.
Well, I came to Rhode Island 24 years ago to work on the HIV epidemic.
Just passing through.
Passing through. And at that time, we had one of the highest rates of injection drug use related to HIV in the country. One of only 4 states with more than half of the AIDS cases related to injection drug use. Turns out a lot of those people we diagnosed and started treatment at the Department of Corrections at the ACI. So I started going out there every week, and I've been going out there ever since every week to take care of people. We found that HIV was a problem out there, but we also found many other medical problems in that population.
Mm-hmm.
So that's why we founded the Center for Prisoner Health and Human Rights, to draw attention to the health problems related to incarcerated
And your
individuals.
background is?
So I work in internal medicine. I'm going to my last year of medical residency, and I take care of inpatients in the ICU and outpatients who have opioid use disorder. I just came off of a night shift actually, and I've seen many patients with opioid overdose. And
Last night?
Last night.
Nightly?
Nightly.
How many?
In a night, I may take care of 1 or 2 patients who have opioid-related complications or opioid overdose right now in the ICU, especially, who have brain injury from losing oxygen after an overdose. It's really sad. It's horrible, actually.
How do you do that work?
With not a lot of sleep and a lot of coffee, and you just get into a mode where you put the patient in front of yourself and focus on stabilizing them and working with the families and trying to explain what's going on. And
Have you been involved in that kind of work as well?
Sure. Well, I went through a similar training, but not at this time. So what I've seen patients in ICU from overdose,
Sure.
but not the volume that we're seeing now, really across the country. This is it's
Well, so back in your day, I mean,
Yeah.
obviously you're still thriving as a medical professional, but back in your day with the HIV thing,
Sure.
you were seeing a lot of slow death.
Yep.
Right? I mean, HIV was brutal, and I remember, maturity, and the years go by, and it brings you a little bit of perspective. I can still hear myself, on the radio and on television 3 decades ago, saying, you know what, you stick a needle in your arm, that's your problem. Needle exchange is brings down the community. Da, da, da. I can still hear myself saying those things, and over time and after listening, it's kind of what I'm thinking when I see Nick Mattiello speak as he speaks. I mean, I don't think he's mean-spirited in his approach. I just think that there's a on-the-ground professional perspective that sometimes I think gets confused on politics rather than just medical reality out there. So you remember the needle exchange stuff was a fight everywhere. And I remember about 10, 15 years into it, I said, Uncle, too many people are dying. Yeah. It just became one of those situations where the numbers were just too big to argue politics. Agreed? You remember?
So this epidemic is going up, up, up.
Which one?
The opioid
But
overdose
you
death.
can relate to that.
Absolutely.
Because I think there's still a little bit of that going on the opioid side.
Oh, there is. There's a poor understanding of this disease, of why people do that. It's, as we heard, it's impacting pretty much everybody in the state.
Difference
Everybody
being, the
knows someone.
HIV thing, there was a stereotypical thought process involved with that. Drug addiction, drug culture, that kind of thing. Whereas right now in the opioid crisis, we have that, and then we have the regular community that's really been impacted, right?
Yeah, I mean, we're seeing patients who are young, who are old, who are across all socioeconomic groups affected by the opioid crisis.
Okay, why don't we do this? I want to come back. I want to talk. I want to tap the medical expertise here, and hear from these doctors about what is a healthy approach to any opiate prescribed by a doctor, and they will talk specifically about this bill that wants to criminalize, and I mean seriously criminalize, those who have sold this stuff to people who pass from an overdose. We'll be right back. Okay, well, they're prescription pills, no big deal, right? We've done, I don't know, a dozen or more shows with concerned medical and social service experts out there trying to pound home the idea that this opioid crisis is real and it is mainstream. We have a full screen on some of the data here. 320 Rhode Islanders died from opiate overdoses last year. 75% men, 12 to 15% are from the correctional facility. Dr. Rich is intimately aware of that information. Increases in overdose 90% in 6 years. And that's a number, by the way. You ought to write it down, and we'll remind you at the end of the show, 942-STOP. And we'll give you what the number is on that. I get why the letter. Does anybody use letters anymore when they dial the phone? The younger people always laugh about this. I always knew I was hoping I'd be old enough to be looking at a successful young doctor and think, oh my gosh, she's really young. But I bet you night after night in the emergency room makes you feel old, huh? After you see all these folks coming in. What is can you both give me a quick, because I know there's so many things we got to talk about here, give me a quick opinion on how nervous people ought to be when they get their tooth pulled or their knee operated on and they're prescribed Percocet, Vicodin, whatever. I mean, I hate them. I had a tooth pulled. The pain was unbelievable. I took one Vicodin, I think, hated the way it felt, and left it on the shelf until I could give it to the police and that annual deposit of the drugs type of thing. So, but I'm one of those people that just doesn't like to take this, What do you think, real quick? I mean, how worried should people be?
So, first of all, you're like everyone else who leaves their pills in the shelf, and you shouldn't. You should just flush it down the toilet. All opiates, flush it.
Wait a second, I'm told that that's an environmental and health problem.
That's an environmental problem, but the director of the health department said we are in the middle of a crisis, and rather than have a teenager get into that, flush it. So that's new recommendations this past year.
Really?
Yep.
Okay.
But there are drug take-back days if you're not comfortable doing that.
Right.
You can bring them to the police department and leave your opiate prescriptions there so that you don't have them in your medicine cabinet.
Yeah, it's such a mind blower to me that the average American family has to worry about a teenager pilfering their drugs in a medicine cabinet. I mean, luckily, I don't think I'd ever had to or would have to worry about that, but
it's true about a quarter of U.S. teenagers have used prescription drugs, and maybe half of those come from their family. So that's a lot.
Just wandering into mom and dad's bathroom.
Yeah.
Okay. But what is it? What should we be worried about? I mean, everybody's different. Right. Addictive issues are not the same for everybody, right? But I mean, listen, you get a knee operation and you get 2 months worth of whatever.
Right.
Problem?
So that's a problem. But to answer your question, most people who use an opiate don't develop addiction, don't develop this disease. But there are certain people that are at higher risk. If you have the wrong genetics, if you've been traumatized, and then there's some biological.
Traumatized.
So if you were molested as a child and you were told that never happened, if it did, it's your fault, and we don't talk about it, then, which is unfortunately very typical in the population I work with, and then you kind of come into adulthood carrying this burden on your shoulder, and then you get exposed to an opiate, and in addition to helping your knee pain, that junk is just off your shoulders and you feel good. So
I get it. So if the medicine for the knee or the tooth or the weather starts to make you feel better about other things,
takes away your psychological pain.
Gotcha.
Then who wouldn't want to go back to get that? So it could be other kinds of trauma as well. Trauma is almost universal in this population. If it didn't happen before you got hooked, it almost certainly happened afterwards.
I've got buddies who have told me in the past, yeah, well, I'll tell you, I took that Percocet. Ooh, I really like that. Well, and I go, ooh, right? That's a problem.
That's a problem.
That's a problem. Okay, but everybody's different. But is there a general rule for how long is a credible prescription time?
So right now we try and limit our prescriptions, especially people who are leaving the emergency room or the inpatient setting, to just a few days of opiates. The problem is that people have been on them for many years, and when we try and wean them off, sometimes that's done too quickly, or providers get nervous about.
What about the person who's never been on them before and just has an injury? I mean, are you dispensing opiates? I mean, that's got to be a weird deal. Like you give them, right, as a script for people who need them because they got acute pain, and in the next bed you've got somebody who's been hooked for 4
Correct.
years,
Yeah.
right?
We try and focus on other kinds of pain management, but we do use short courses of opiates for patients who have severe acute pain.
But
and
what are you
surgical.
talking about amongst yourselves as doctors about what is the
Yeah.
what's the proper protocol?
So you should distinguish acute pain versus chronic pain. And acute pain is, you know, you just broke your leg, you just got operated on, you just had some severe pain. That's going to resolve quickly. And we overprescribed for the last decades, and we're realizing...
Too many pills left in the bottle.
Yeah, and too long for too many people. And most people are just going to put it in the medicine cabinet, but some people are going to get hooked and then going to go back and get more and more and more. But
Is
the
it weeks? Is
epidemic,
it months? What is it? What is it? Somebody on the couch
Well,
right now is going to tell me what's the safe zone? Is there one?
well, you know, I'm not sure you can simplify it as a safe zone or not.
Or is it
really-
more about what you were saying? Hey, this makes me feel.
Right.
Right.
So it's not just about, oh God, my knee feels better. Thank God. It's, hey, this
Now-
is pretty cool. That's the problem area.
That's more of a better description. Chronic pain, it's easier to just write a prescription and give pills, and it's the insurance companies favor that, but that's not very effective compared to comprehensive approach.
But it's a
Physical
lot of
therapy.
work. It's a lot of work, and it's a lot of time to take care of, and expense to take care of somebody who has chronic pain. And we're not good at taking care of chronic pain. Our inpatient and outpatient settings are designed to take care of people in a short period of time, to see as many patients as possible. And like you said, it's easy to write a prescription and say, "Be on your way. We'll see you in."
All right, you doctors got a lot to talk about amongst yourselves. When we come back, let's talk about the bill and talk about what they've learned at the ACI and more about this environment. Stay with us. All right, and so this op-ed piece by my guests intrigued us. Let's cut right to it. And I want to make sure that I understand something here, and both doctors reminded me during the break that the pill and prescription crisis is kind of hit its top and is somewhat what? Leveling
Decreasing,
off.
yeah.
But now we've got an illegal drug environment out there with fentanyl-laced opiates.
Yeah.
What's the main drug? Heroin?
Yeah, main drug that's been used is heroin, but most heroin in Rhode Island today is contaminated with fentanyl.
Right. Heroin is a replacement on the street for prescription opiates for a lot of people, right?
For some people, that's true. When they were unable to get more prescription opioids, they went to use heroin.
What's
That's
going
true.
on? You know, who's lacing this stuff? Who's doing this and why? What's the purpose?
So we don't know completely, but heroin is semi-synthetic. It comes from the poppy plant, has to be grown on a hillside somewhere, transported, processed, brought into Rhode Island. If you imagine a cooler full of heroin brought into Rhode Island, a comparable amount of fentanyl, which is not semi-synthetic, it's fully synthetic. You can make it in a lab. You just need some chemicals and a chemist. That'll fit into a cigarette box.
Ultra
So it's
concentrated.
much more concentrated, much cheaper to manufacture, much easier to transport.
What's the benefit? Who's benefiting by fentanyl included in these drugs? Is it is it when fentanyl is introduced into a heroin purchase? Is it immediately fatal, or is there some kind of like cool high that it's like, you know, maxing out the
That's
process?
a misconception about how people die of an opioid overdose. Opioid overdose comes from respiratory depression, so you slowly stop breathing, and that's how you die. It's not instantly fatal, but it is so much more potent than heroin.
Which is why the Narcan is so effective, right?
Yeah, yes, naloxone,
Right.
trade name Narcan, is a reversal agent that binds to the opioid receptors.
I'm just trying to get to motive. Why is fentanyl going into these drugs real
Yeah.
quick so we can talk about whether we
So-
ought to jail these people?
By overprescribing opiates, we created a generation addicted to opiates, and their tolerance went up, and their need for more and more and more went up. And when they couldn't get it, they switched over to heroin, which was cheaper, and more abundant. And then when heroin became harder to get, then fentanyl entered the market. So it's really a demand.
So
an
if people are buying
insatiable demand.
fentanyl, they know they're buying fentanyl.
A lot of people don't know that the heroin is laced or cut with fentanyl.
All right.
They don't know.
You say this bill is about to be passed that would lay heavy, heavy crime on the seller of this crap to somebody who dies from it.
Yep.
And you both think that's wrong. We have 3 minutes here, 2.5 minutes. Tell me why.
Well, first of all, it makes no sense. You're going to take out the little fish and you're going to spend a lot of money incarcerating them. This bill, up to life imprisonment, that's $1 million right there. And we're going to spend $1 million out of the Rhode Island budget to lock someone up that's going to have absolutely no impact on the distribution network.
Because these are the people at the bottom of the distribution network. These are the people who are selling to their friends, selling to their families in small amounts. And of course, they're the last person to have seen the person who dies of an overdose because they're the one who handed them the drug.
And they may not pick up the horn and say trouble, correct?
They may be afraid to, but they...
But we have a Good Samaritan law in place that gives them somewhat of a break, no?
I worry that won't be enough.
It won't, this bill will say, okay, you can call 911, but if the patient doesn't make it, actually we're going to give you up to life imprisonment.
Yeah, that doesn't make any sense.
Yeah.
I mean, it's like it's a crapshoot call. It's like, oh, I think they're okay. I think they'll make it. I'm going to call, and I don't have any criminal liability. But if they buy the farm, I'm all done.
So we should focus on what actually works.
Which is what?
Which is treatment. We have 3 medications approved to treat opiate addiction. They're highly effective. You mentioned the ACI. We rolled out with Governor Raimondo's task force, led to rolling out a program that actually treats people and links them to treatment on the outside. With that program, there was a 61% drop in overdose deaths statewide.
Well, that's her task force. What do you think she's going to do with this bill that likely is going to go to her desk that would severely criminalize the seller?
So that's really a political calculus decision. I think, you know, right now we have people that are serving up to life sentences on the existing laws. So in reality, another law that's just as foolish as many of the others. I think the bigger question and the challenge for the state of Rhode Island is, what are we going to do that's really going to work? So I mentioned treatment, but in Portugal, where they had the worst drug problem in all of Europe, 15 years ago they decriminalized possession of syringes and put resources into treatment, and they now have the lowest rates of HIV, the lowest rates of drug use,
a 90% drop,
and lowest rates of incarceration
overdose
in the entire European continent.
All right, why don't we do this? I'm going to thank my guests. I'm guessing that the governor is going to be contemplating this over the course of the next week or so. I'd like to come on the radio and talk more about this, take some calls, and have this public discussion next week in the midst of this deliberation. Will you do that? Will you do that with me?
Absolutely.
Awesome. So we'll let you know when that's going to happen. Thank you very much for coming in. We'll tell you what's coming up next week. Stay with us. Listen, program note, we are most likely not on the midnights here for the next few weeks because of the World Cup Soccer Fox Network preemptions. We haven't gone away. So you got to watch the show at 7:30. We're going to do a radio program on this conversation about this opioid issue, most likely Monday or Tuesday. And the Teacher of the Year will be here Monday on television. See, I got to go.